Hi there, my name is Dr. Matthew Leonardi. I'm a gynecological surgeon and sonologist at McMaster University in Hamilton, Canada. I would like to thank the MIS Academy and the World Endometriosis Society for the opportunity to speak today at Endo Dubai 2021. I'd also like to thank my co-presenters during this session, Ms. Lonne Humelshoy, Dr. Lucy Whitaker, and the moderator of the session, Dr. Soni Singh. Today, I'm going to be speaking with you about how to best prepare for surgery for endometriosis by using advanced imaging principles. Here are my disclosures. And here is how I can be contacted. So you can get in touch with me by email or via any of these social media platforms. For those of you that are already on social media, you'll know how exciting an avenue it is to network and learn. For those that are not, I encourage you to check it out. Over the course of today's lecture, you're going to see a number of QR codes, which will take you to various articles that I reference. All you have to do is open your smartphone device, shine the camera at the QR code, and a link should pop up somewhere on your screen. Click that link and it'll take you directly to the article. Today's talk is going to focus on ultrasound for endometriosis. We know that ultrasound has the ability to both diagnose endometriosis and play a huge role in the management of endometriosis. Today's talk is going to focus more on how we use the tool as a device to optimize management rather than to actually diagnose the disease, but they are quite inextricably linked. We can also replace ultrasound with MRI if ultrasound is not available to people. The principles in today's talk are going to be the same. For me, as a surgeon and a sonologist, one of my guiding principles is that I do not want to be surprised by what I find at surgery. And I think probably most of you listening today who are surgeons will feel the same. Of course, the rectouterine pouch obliteration you see here on the right is a state that no surgeon ever wants to accidentally encounter. On the flip side, and maybe more importantly, patients should not be surprised by what they learn when they awake from surgery. So surgeons should be able to guide patients preoperatively, inform them what they intend to see, what they intend to do, and when the patient wakes up, it should go according to plan. These are my two guiding principles. Today's talk is going to identify some broad principles with examples using lots of imaging on why ultrasound is an essential tool when planning surgery for endometriosis. And so I'd like to divide this talk into two sections, essentially, the before consent part and the after consent part. Informed consent is a process whereby patients are told the findings, summary of what needs to happen, and patients are given a chance to make a decision about various treatment pathways based on all of this information. So a big part of the before consent process is based on imaging findings. A surgeon will plan surgery if a patient consents for surgery based on a number of factors. And of course, imaging is going to be one of those large factors. So taking the before consent process, patient will present with signs and symptoms of endometriosis, and we will perform a clinical history, physical examination, and an ultrasound. Of course, transvaginal ultrasound is ideal, but transrectal ultrasound can be utilized, and MRI as an alternative can be utilized. These tools can give us a diagnosis as well as an understanding of the disease. This information then goes into the discussion with the patient to allow them an opportunity to make a decision that's best for them, which can include management strategies that are medical, surgical, or complementary and alternative. And of course, in endometriosis, we understand that a combination of these tools is usually essential. For today's talk, we're going to be focusing on surgery. So when a patient decides to proceed with surgery for endometriosis, we're going to use our ultrasound findings to help optimize our surgery. So the things we can learn from ultrasound include mapping of disease, severity assessment, What surgical skill might be necessary when we're actually performing the surgery? Who needs to be present from a consultant surgical service point of view? And finally, how long do we book the surgery for? Of course, if an ultrasound is normal, with no evidence of deep disease, advanced adhesions, we will not anticipate the surgery taking very long. If the patient has advanced disease as demonstrated on imaging, we're going to account for that in our operative time planning. To clarify the concept of diagnosing and understanding endometriosis on ultrasound, we need to take a step back to understand what the current standard of care ultrasound is for patients with pelvic pain and in general. According to the American Institute of Ultrasound and Medicine, as well as the Canadian Association of Radiologists, and a number of other organizations around the world, an ultrasound should look at the uterus, the ovaries, and the rectouterine pouch for fluid or mass, which is quite vague. When we look at the uterus, we may encounter fibroids or adenomyosis. When we look at the ovaries, we may encounter ovarian endometriomas. But otherwise, we're not going to be able to understand the disease presence outside of those structures or the severity. So there is a new ultrasound in town, and this would be called the deep endometriosis ultrasound or the advanced ultrasound. And this looks far beyond the uterus and the ovaries. It looks at, of course, the uterus and the ovaries for the same features that we look at on a basic pelvic ultrasound, but we also look at the other visceral structures in the pelvis for direct visualization of deep endometriosis. That's the bowel, the uterosacral ligaments, the bladder, the vagina, and the rectovaginal septum. We also look for soft markers, which include ovarian immobility, a sign of adhesions. We also look for obliteration of the rectouterine pouch, which is measured using the sliding sign, either as positive or negative. So the potential for the advanced imaging tool is significantly greater than the basic tool. So out with the old. Who is responsible for directing this approach? The International Deep Endometriosis Analysis Group, the IDEA group. They've published a landmark paper in 2016 that outlines the approach to performing ultrasound for endometriosis. Here is a QR code that will take you directly to that article. This group is an international collaborative that has worked together for a very long time on optimizing the approach to endometriosis ultrasound. The principles published in this paper have been utilized as well in the realm of MRI. So it's generalizable outside of ultrasound. Professor George Condis and I have put together a very practical approach to performing the ultrasound. The IDEA article is very theoretical, very scientific, not as instructional. So we put this together, and the QR code will take you directly to that article. And you can see here the rough approach for the ultrasound, which starts with the bowel, moves to the uterus, the adnexae, the anterior compartment, followed by the posterior compartment, and ends with site-specific tenderness, which unfortunately is something that many patients experience. So performing it at the end of the ultrasound allows for the patients to best tolerate the entire procedure. From an ultrasound mapping perspective of deep endometriosis, we have here a video that depicts a deep endometriosis nodule of the posterior vaginal fornix. This, of course, might be palpable on examination. It might be visible on speculum examination, but understanding the full extent of it is really only possible using imaging, because imaging can see through structures. So we can appreciate the nodule, which is just here. This is normal vagina here. And we can appreciate the irregularity of the overlying peritoneum, which has just got some fluid adjacent. But importantly in this video, we're also appreciating that the bowel is very close. It's tethered to the area of disease, but not actually directly involved with the endometriosis. So in order for this bowel to be dissected downwards to allow for the nodule to be excised, advanced surgical skill is necessary. In this video here, we have a number of features. We have a retroverted uterus that is fixed to disease in the posterior compartment, in the bowel, and in the uterosacral ligament. We have a negative sliding sign. And I show this video to help people understand that ultrasound can see through things that we cannot see through with our eyes at surgery. When one has an obliterated rectuterine pouch, we usually can't see past this point. We can see the uterus, we can see the adhesions, but we don't really see what's deep to the adhesions. And so ultrasound can see through and allow us to know that that nodule is there. And as we dissect deeper and deeper, we can target that lesion to ensure complete excision, which is our main goal when we're doing surgery for endometriosis. When we're trying to understand the severity, we look to staging systems. We look to the ASRM staging system, maybe the Enzian staging system. And we know from research that we have performed in Sydney at the University of Sydney under the supervision of Prof. Condis, that ultrasound can accurately predict the advanced stages of endometriosis. So with ultrasound, we can predict the ASRM 2, 3, and 4 with accuracy in the low 90s, high 80s. ASRM stage 1 is still very difficult to predict. ASRM stage 1 involves superficial endometriosis of the peritoneum usually, which is the hardest type of endometriosis to see on ultrasound. And so we're not very good yet at predicting the early stages. But when grouped into ASRM 0, which equates to no disease at all, 1 and 2, versus ASRM stages 3 and 4, we can predict this dichotomy with almost 95% accuracy, which really means that we should no longer be encountering advanced disease at ultrasound without knowing at surgery without knowing about it preoperatively. Here's a QR code that will take you to ResearchGate to access this article. In this video here, I'll point out a few things. We have an ovarian endometrioma. We have deep disease of the posterior compartment in the torus uterine and uterus sacral ligament, and we have bowel endometriosis just here. All of this is part of a negative sliding sign and obliterated rectuterine pouch. This is stage 4 endometriosis. Although, of course, as many of you know, the ASRM staging system doesn't incorporate deep endometriosis of the rectum, which is a distinct entity. But in this video alone, we can appreciate that the severity of the disease is extremely high. And that means that the complexity of the surgery will be very high. So this video alone will direct a surgeon to prepare for an advanced surgery. We've made reference to the sliding sign in a few of the previous videos. Essentially, the technique can involve the movement of the ultrasound probe with or without the hand that is non-scanning. And so you can ballot the uterus. And in this video of a positive sliding sign, the hand holding the probe is stationary, while the hand that is not holding the probe, the non-scanning hand, is simply ballotting the uterus above the pubic symphysis, which is allowing the uterus to slide beautifully along the content posteriorly, which is the bowel. In contrast, the negative sliding sign is depicted here. The hand, again, the non-scanning hand, is ballotting the uterus, but is not able to elicit a sliding between the uterus, the posterior uterine serosa, and the content posteriorly. In this video, we're also seeing that negative sliding sign in a retroverted uterus. So the technique implemented here is simply pushing in with the probe, which is often all that is necessary when you have a retroverted uterus. In this video, we also see a bowel nodule, which is quite a large bowel nodule. And then finally, in this video, we have an anteverted uterus, and the probe is sitting in the anterior vaginal fornix, applying pressure in and out. We're not achieving a sliding here, so this is the negative sliding sign. And we also can visualize here a deep endometriosis nodule in the bowel. In order to optimally visualize this nodule, I would recommend placing the probe in the posterior fornix so as to bring the probe very close to the nodule, which is essentially what we saw in the last video. Now, some of you may have heard of the ultrasound-based endometriosis staging system, UBES for short. This is a system that was initially published by Prof. Condis and the other authors from his institution. And when I joined, we also published on this concept. Essentially, ultrasound features can form a composite complexity, and that can equate to surgical complexity. And in some countries around the world, there are surgical complexity systems that allow for surgeons to understand where their skill is and what they can do in surgery. So in Australia and New Zealand, the RANSCOG organization joined with AGES, which is a surgical organization, to essentially state which level of skill a person needs to do certain surgeries. And so we compared the UBES stage, which is determined using these features on ultrasound, and primarily dictated by the obliteration state in bowel endometriosis. We equated the UBES system with the RANSCOG surgical complexity system. And essentially, in order for somebody to perform surgery at the highest level, the RANSCOG 6 level, this would correlate best with the UBES level 3. There are some limitations to the UBES system that we are working on refining for future iterations. Another beautiful synergy of ultrasound in surgery is a study published by Dr. S. Eng from Norway, a study that I was fortunate to contribute to with Prof. Condis, comparing the measurement of the bowel nodule from the anal verge on ultrasound to that same measurement obtained at surgery. And so we determined that there was a very good agreement between the ultrasound measurement and the surgical measurement. Why is this important? Well, when a patient has a bowel nodule and a surgeon is thinking about performing bowel surgery for that endometriosis, segmental resection is a real possibility. There are various types of segmental resection, and each of the different types of segmental resections have different risk profiles. So understanding preoperatively which type of segmental resection might be necessary allows for the surgeon to prepare and the surgeon to tell the patient what they believe their risks of surgery are going to be, which comes back to that important principle of informed consent for the patient. So this study was really helpful in determining that. Talking a lot about surgical skill of surgeons, one of the most challenging procedures to do is a ureterolysis. And we know that's often necessary when endometriosis is present. In these pictures, we're depicting an ovary stuck to the uterosacral ligament where there is a deep endometriosis nodule and a congruent ovarian endometrioma. And the ureter is running right underneath that path. So in order to perform a complete excision, a ureterolysis is necessary, which does necessitate high level of surgical skill. This ultrasound video depicts that exact patient. So we have our ovary depicted in the center of the screen with a small endometrioma just here, adjacent to our uterosacral ligament to which it is attached. And we're not seeing the ureter in this video, but it is running exactly underneath this area. Here's that surgical depiction in a video form. So we have our ureter, and a ureterolysis has started and it's going to continue. And in order to mobilize that ovary and excise the deep endometriosis of the uterosacral ligament and really normalize the anatomy, surgical skill needs to be present in order to do that. And preparedness is really important. So knowing that the ovary is stuck in that area, there's an endometrium and there's a deep endometriosis nodule is all very important preoperatively. In that last case, we didn't require the assistance of a urologist, but in this case that I'm presenting, we did. We have a deep endometriosis nodule of the uterosacral ligament extending into the perimetrium. This is the surgical depiction of that. And the overlying labels demonstrate that the ureter is very close to that. It's very difficult to tell just based on the laparoscopic view how deep this goes, but it is essentially extrinsically compressing the ureter, causing a hydroureter. In this video, we can see this very clearly. Here we have our uterosacral deep endometriosis nodule and the hydroureter that it is causing. In this patient, preoperative consultation with urology was done, and the patient was consented to a ureteral reimplantation, which was performed at the same time as the excision of endometriosis. So in the past, a lot of these patients with complex disease would have undergone what we call a diagnostic laparoscopy, which may have been abandoned due to complexity of disease that was not able to be addressed at that same surgery, resulting in an interval of time before an operative laparoscopy was performed by an advanced surgeon. Diagnostic laparoscopy is still performed around the world today quite a lot, but with advanced imaging and advanced ultrasound in particular, we can negate the need for a diagnostic laparoscopy because we can predict these advanced states in the majority of cases non-invasively, allowing for the appropriate triaging of patients to surgeons with the adequate skill level, as well as the consultants in colorectal or urology surgery. And that will mean diagnostic laparoscopy may become something of the past. To conclude, everybody here who's listening is likely involved in surgery for endometriosis or decision-making around it. And so we all understand that surgery for endometriosis has outcomes and it has risks and complications. We want to balance the outcomes, the positive outcomes, hopefully, with the risks and complications. In order to do that, we can perform preoperative imaging, preoperative ultrasound, to improve our outcomes, which are going to be based on thorough understanding of the disease preoperatively to target all of the disease sites. And that will hopefully also result in a decrease in the risks and complications that patients experience. Now, you can take a step back and apply this same concept to the overall management of patients. It does not have to be surgical, but having advanced understanding of disease state in a non-invasive fashion will give you, as the clinician and the patient, the ability to make a decision that's best for that particular patient, an autonomous patient-centered decision. I'd like to thank the MIS Academy and the World Endometriosis Society again for the invitation to speak today. It has been a great honor. You can get in touch with me via Twitter, social media, or by email. And I do encourage you to consider attending in the very near future, just next week essentially, the World Congress on Endometriosis, which is going to be an incredible, incredible event. Thank you again. Bye-bye.